Shenbulu's. I'm an associate professor in psychology over on the main campus, so we're really grateful for O'Brien for hosting this today. This is Dr. Katrina Debnam. We've been colleagues for the last decade, and we're really lucky to have her on campus this month as our visiting scholar in psychology. Just a bit of background on Katrina. So she is an associate professor of education and research statistics and evaluation in the School of Education and Human Development at the University of Virginia. She also holds a joint appointment in the School of Nursing at UVA and an adjunct appointment in the Department of Mental Health at Johns Hopkins Bloomberg. Dr. Debnam has a master's of public health degree in health behavior and health education from UNC Chapel Hill and a doctorate in behavioral and community health from the University of Maryland College Park. So grab some lunch and stuff. Her scholarship focuses on health outcomes for marginalized adolescents to community response prevention. And today she's going to be specifically talking about work she's done with young Black women around violence and violence prevention, which is amazing work. And I'm so glad she's going to share it with us. And just want to acknowledge that we're so grateful to gather today on the homelands of the people of Treaty 7, as well as the Stone Lakota and Tsuut'ina peoples and the Otipemisiwak government. So without further ado, so we'll go for about 50 minutes and then we'll leave time for Q&A as well. Welcome, Katrina.
Thank you. Thank you for that wonderful introduction. Thank you for having me here. Thank you for allowing me to present these lands. So I am going to attempt to take you on a little bit of a journey through a grant that I received with my co-author here, Lenise Avery. We're co-PIs on this particular study that we've been working on for about 3.5 years, almost 4 years now. And to tell you a little bit about how the work that we did and how we got to where we are now, and weaving in some lessons learned along the way, and ultimately to talk about some of the mental health outcomes that we see for young Black women. I will attempt to be clear and be concise and to make sure you can hear me. Can you all hear me at the back of the room? Okay, great. And then for Zoom. But make sure, please let me know if I trail off or if I start to talk too fast. That's a thing that I tend to do, and I'm not always aware of it. So make sure, please just, give me a little hands up if I go a little bit too quickly. There's been a growing interest, at least in the U.S., about in the ways that Black women confront unique forms of discrimination and violence at the intersection of sexism and racism. These systems of oppression often position Black women in the margins of society, where they are forced to navigate gendered, racial kind of mythologies that were developed to justify the violence that was routinely enacted upon them and still is. With this in mind, I'm going to walk you through how we center health equity and youth voice in our work and improve mental health outcomes for young Black women. So before we do that, I'm a qualitative researcher. I like to kind of ground my conversations in my positionality and reflexivity. My reflexivity informed my positionality. And there's a way that growing up in the US in an urban area, being confronted with images about of violence against women, being personally knowing people who have been violated or abused by their partner or been killed by their partner, this all tends to speaks to the ways that I think about the work and why I'm so passionate about it. So it would be naive of me not to acknowledge the fact that it does have a role to play and why I decided to do the work, how I go about doing the work, how I think about it, and all things. So just wanted to acknowledge that. So intimate partner violence, or IPV, is a pervasive public health problem in the United States, especially among young Black women who experience violence at greater rates than their female counterparts. According to the National Intimate Partner and Sexual Violence Survey, which is a semi-annual survey that goes out annually in the U.S. for women, Black women reported higher prevalence rates of lifetime IPV compared to white and Latina women. IPV has, of course, numerous physical and mental health consequences for women, and the most common being greater rates of depression, anxiety, post-traumatic stress disorder. Several studies have indicated that women who seek help and receive emotional and tangible support may be less likely to receive some of the psychological impacts of their experiences with IPV. Yet there is a lack of research that examines association among Black women survivors in the context of their unique gendered and racial cultural stress that they experience. And so particularly the culturally prescribed behavioral expectations that they're socialized to endorse. So talking about those cultural portrayals, Black women, as I mentioned at the beginning, face unique forms of discrimination violence as a result of these interlocking systems of oppression at the intersection of racism and sexism. These systems often or have relegated Black women to the margins of society, and their subjugation is maintained in part by the prevalence and kind of persistence of these negative gender racial mythologies that characterize them either as these hypersexual, what we call Jezebels, angry and verbally aggressive sapphires, servile and kind of self-sacrificial mammies, and then kind of this subhuman, durable, and resilient, strong Black woman. And if you watch media with Black women in it, you'll often see these roles or characters playing out in movies and TV shows. They are cultural portrayals of Black women that we have endured. I'm speaking specifically about the Strong Black Woman Schema. This one is particularly rooted in these kind of racist myths about Black women being mentally and physically stronger than white women to justify their kind of systematic dehumanization and exploitation during enslavement in the U.S. The Strong Black Woman Schema prescribes a complex set of beliefs and behavioral expectations for Black women. So SBW has been described as kind of restrictive and controlling, culturally specific gender schema that establishes social expectations for Black women to uphold a set of central characteristics. And so including demonstrating emotional strength, self-reliance, stoicism in the face of adversity, prioritizing the needs of others above their own. So these are just some of the characteristics that are notable for the schema. As such, Black women who strongly endorse the schema may routinely mask or minimize or deny experiences of emotional pain, which has been associated with adverse post-traumatic outcomes for them. So, however, exuding strength while concealing vulnerability and pain is a behavioral mandate that sometimes is often praised and exalted in different places in society. So, having persisting and having resilience and being independent is often praised and promoted in the workplace, right? And so there are ways that there are some, while there are negative consequences, there are also some positive things that are happening because when they do endorse this particular schema. We do see in research, there was a systematic review conducted by some psychologists about 2 years ago that looked at the range of outcomes that have been associated with SBW. And so we saw that in that systematic review that it was related to increased depression, anxiety, emotional avoidance, irregular sleep. So also physical outcomes, binge eating, smoking, and even risky sexual behaviors. So the outcomes for this endorsing the schema are wide and vast. So Black women, however, are not passive victims of IPV. They employ various survival and help-seeking strategies while in abusive relationships. So many enact internal, interpersonal, and external strategies to survive the abuse until they're able to safely leave the relationship. Yet there are many barriers to help-seeking for Black women who experience IPV. Waller and colleagues document negative experience with the criminal justice system, emergency housing, healthcare, and the mental health systems, as well as the Black church that sometimes hinder help seeking for women. And Trisha Brent Goodley theorizes about the effect of what we call racial loyalty on help seeking behaviors, where Black women withstand abuse and make a conscious self-sacrifice for what she perceives as the greater good of her community, but to her own physical, psychological detriment. So racial loyalty manifests in her views as unconditional support for Black men, which will sometimes delay or inhibit them from seeking support when they're experiencing abuse from them. So the theory of reason action posits that intentions to perform a behavior can be predicted by one's personal beliefs, their attitudes, and the subjective norms about the behavior. The subjective norms operationalized by SBW schema compel women to exhibit strength, self-reliance, self-silencing, and self-sacrifice in response to pain and adversity, which may negatively impact their health-seeking attitudes and behaviors. However, there is a lack of, there are critical methodological behaviors, barriers to the ability to empirically test the influence of social cultural norms like SBW on help-seeking behaviors, due to the reliance on these kind of psychometric tools that are not designed to capture Black women's endorsement of these gender racial stereotypes that I talked about within a specific context of sexual and romantic relationships. So the current measures that exist include those that assess Strong Black Woman Schema, focus on these global attitudes about gender racial expectations for Black women across contexts, specifically about their family, without specifically focusing on intimate partnerships and violence. So as such, my colleague and I set out to kind of develop a psychometric tool that would help us better understand how the schema endorsement might influence or moderate the role of help seeking for women who may be experiencing abuse and ultimately their mental health outcomes, right? So the aims of the grant were to, one, develop the Strong Black Woman Schema and Intimate Partnership Scale to assess its content validity and item clarity, examine the reliability and constructability of the scale, and then test associations between the scale, IPV, help seeking, and mental health. And so I'm going to talk you through the number of steps that we use to get to this ultimate outcome. We use an exploratory sequential mixed methods design to develop the Strong Black Women Schema and Intimate Partnership Scale. I'm just going to say SBW from now, so you know what scale I'm talking about. To then explore the content validity and item clarity in aim 2, and examines reliability and constructability in aim 3, and then to test our structural model for mental health outcomes in aim 4. So I'll talk you through each of the steps that we've gone through to work on this for the last few years. So the first step was to conduct a scoping review. We explored the databases like Info, PubMed, Web of Science, and CNIL to look for in the literature where these SBW specifically was being talked about in the context of intimate and romantic relationships. So not necessarily about abuse, but just in the context of relationships, how this particular schema operate when you're in a relationship with someone. And so we only found 6 articles that talked about this at all. And what we saw across those articles were these 3 themes: that there was a prioritization of their partner over their own self-care. So Black women expressed a perceived obligation to provide unconditional support and care for their intimate partners and postpone care for themselves, which may adversely impact their well-being. We saw a theme around resisting displays of vulnerability, so the reluctance to exhibit emotional or physical vulnerability, which may contribute to a low occurrence of help seeking from public sources of support. And then we saw a sustaining commitment to independence, even while partners. So the strong Black women ideals may influence Black women's relationship beliefs, including hampered expectations for relationships, compromise and mutual respect, interdependence, trust, and a reciprocal kind of physical and structural support from their romantic partners. So the findings from the scoping review are published in Trauma, Violence, and Abuse. So if you want some more in-depth information about that, feel free to take a look at the article. So using the findings from the scoping review, we set out to do focus groups to further examine the content validity. What would be in the content of this measure that we were going to develop? And so we conducted 8 focus groups with Black women in the US. They all were between the ages of 18 and 30. So these were young Black women. And we used, like I said, the protocol that we developed was based on the scoping and review themes. We wanted to see how they talked about these themes that we saw across the literature, and that there were other things that they saw were important in how they were using SBW in their intimate romantic relationships. We used the radar methods for a quick analysis of the data to start to work on, to get to developing the items for the measure quickly. So findings from the focus group interviews revealed 5 patterns. So these 5 themes demonstrating the unique ways of Black women's adherence to SBW schema prescriptions were exhibited in intimate relationships. So they talked about Black women confronting expectations to uphold strength in their relationships, a commitment to independence, even while they were partnered, even if they were with someone, the ways that they maintain their own independence. Efforts to engage in emotional concealment with their partners, so not always showing when they were upset or sad or angry, so concealing their emotions. and aspirations to achieve equitable caretaking in relationships. They often said they wanted equitable caretaking in their relationships and didn't want to be self-sacrificial, but they weren't experiencing the care that they were demonstrating to their partner, and a desire to portray a positive relationship image. So to the public, to their family, to their friends, that they want their relationship to be seen as in a positive way by others. So these, using these themes, we use these then to create our items for our measure. So I know you cannot see this slide, but I wanted to kind of talk through how we went about doing this. So when you're doing qualitative analysis, you often are coding the transcripts, right? So we develop codes as we were developing or analyzing the data, there are the codes that were come up related to each of the themes. And so we use those codes to then develop items, individual items for each subscale. So really using the data, really using the voices that we heard from our participants, from the responses, to develop items to really showcase what they were telling us they were experiencing or doing in their relationships. And so in developing and creating these items, we developed this preliminary measure using that had those 5 themes, those 5 subscales those 5 themes became 5 subscales. So we have a positive relationship image subscale, where we developed 21 items, self-sacrificial caretaking subscale that had 19 items, a strength and perseverance subscale that had 14 items, emotional concealment that had 20, and then an independent subscale that had 14. So that's a lot of items. And so the next step was to really try to get some more feedback about these individual items that me and Dr. Avery, my co-PI, and our research team had developed, right? So the next step was to conduct cognitive interviews. And so cognitive interviews, if you're not have never done them before, they are a really great way to get really detailed, specific information about items on your scale or on an instrument. You're conducting an interview with your participant and lead them through each of the items in your instrument to ask them how they are understanding it. So that's what we did. We did 12 interviews with Black women, again, ages 18 to 30. And each interview, we viewed the items from one set of scale. And so we did this in 2 ways. We used verbal probing during the interviews, where we asked them to comment on what did they think the question was asking them? What did they think when they read the question? How would they have answered the question? What, if any, experiences did the question make them think of when they answered it? And if there were any wording, there was any wording in the question that influenced their response. So we asked them asked each of these questions about each of the items on the scale. And then we even asked them to think aloud for each item. So we had them read the question out loud and kind of talk through their initial impressions, what they thought it was asking them, how they might answer, think aloud. So we had both types of answers to glean some insight from. So based on the cognitive interviews, we were able to do some additional instrument refinement. We went from 88 items to 68, which I think we were happy with that. It was still high, but so we went over retaining some items. We deleted a bunch of items. We revised a lot of items. We got some really good insight about how to improve the comprehension and improve kind of the specificity of the scale that we were using. And then we developed just a few items. We were happy to see that we felt like we sufficiently covered each of the domains and the items that we had developed for the measure. We created a Likert agreement scale. So we were debating between whether or not we would use a kind of agreement scale, so from strongly agree to strongly disagree, or a frequency scale. We got feedback during the interviews that agreement scale was going to be better. Created some instructions for the measure and considered how we might order the items. So at this point, we thought we had a fairly decent measure that we could then field and test the psychometric properties of and do some construct validity. So the next step was to do that, to do some survey data collection and analysis. So we fielded an anonymous online survey that was conducted using a Qualtrics panel. So Qualtrics helped us recruit administer and compensate the participants in this particular step of this phase of the study. And the survey in full took about 45 minutes. And so that wasn't just our measure. I'll explain to you the other measures that we also collected to kind of validate what we were doing. Data collection took place in 2004. And so we wound up with approximately 1,977 Black women to participate in the study. All of them, one of the requirements is they had to be currently in a relationship. How they defined the relationship was up to them, but they had to be able to say that they were in some kind of intimate or romantic relationship. There's some demographics of the sample here. They were all 18 to 30. We got really great diversity in sexual orientation. So 66% heterosexual, 22% bisexual, 7 lesbian, 2 queer. We had some good ethnicity diversity. So we collected information not just about their denoted race, that they were Black, but also whether they consider themselves multiracial, whether they consider themselves Afro-Latina, of African origin, or West Indian or Caribbean. So we were able to get some more information about their additional ethnicities that they were represented in the sample. Also about socioeconomic status, whether they were students, whether they were employed, and then their household income. So we were fairly happy with the amount of diversity that we were able to obtain through the cultures panel. So using we started out with this kind of 68 item SBW scale. We collected, let me go back to this and look at this first. So we collected that was part of the survey, the 68 item scale, but we also collected these other measures. So to measure IPV victimization, we used the physical violence subscale of the National Intimate Partner and Sexual Violence Survey. Remember I took that's a survey that is asked annually in the US. We also used a multidimensional 37-item Marcia scale developed by some colleagues at Boston University that assesses more contemporary forms of aggressive acts, including reproductive coercion, sexting, online abuse, and other forms of dating abuse that may have been absent from some of the older instruments that exist out there. We collected information on help seeking. So participants were reporting, who reported that they had experienced violence in the past 12 months. We asked them about who and when did they contact when if they wanted help. And then our mental health measures. So we collected the post-traumatic stress checklist for that looks at post-traumatic stress symptoms, and then the depression, anxiety, stress scale. So all this data this is all the measures that were on the survey that took 45 minutes. So in collecting the data, the first step was to try to look at the psychometric properties of the scale that we developed, right? So we conducted an exploratory factor analysis using the R package to ascertain the ideal number of items and factors for capturing the dimensionality of the item set. So EFA results were supported by our CFA results on a test sample using the R package and indicated a final 29 item SBW scale comprising of the following 5 theoretical dimensions. So we went from 68 items to 29 after our psychometric analysis. So we maintained this emotional concealment subscale that contained 7 items, included items like I try to avoid crying in front of my partner when they have made me upset. Self-sacrificial caretaking scale, again with 7 items. I'm willing to go without so that my partner has what they need. Commitment to independence while partnered. This was just 5 items. I do most things for myself to avoid being a burden to my partner. Shielding to curate a positive relationship image with 6 items. I have misled or lied to others in order to hide problems in my relationship. And then a strength and perseverance scale where with just 4 items where my partner sees me as a strong one in our relationship. And so this is the scale that we ultimately use to then do our construct validity assessment. And I'm happy I do have all of the items listed somewhere in my slides. So if you want, we can talk about that after I finish. All right. So the results. So I should note that we have just finished doing some of this analysis, and so it hasn't been published yet, but it is, we are really excited to see some of the outcomes, and maybe excited isn't the word I should be using, but we are happy to see that the measure is performing the way we expected it to in our analysis. So to test our conceptual model, we conducted moderation analysis using the Hayes process model to examine whether SBW moderated the association between physical violence victimization and depression, anxiety, and PTSD. And so first we use this NISVS, that physical violence victimization scale. And so the overall model was significant and explained about 8% of the variance in depressive symptoms. So findings indicated a significant positive relationship between violence and depression, as well as a positive effect of SBW on depression. So the interaction between the physical violence victimization and SBW was significant and negative. This in further analysis suggested that the SBW buffered Black women from the adverse impact of physical violence victimization of depressive symptoms. We did a second moderation analysis for anxiety and saw the same association. So this kind of positive association between physical violence and anxiety, as well as the positive effect of SBW on anxiety. And then with the moderation analysis, saw that it was buffering the effect of the symptoms of the physical violence on anxiety. And the same story can be said for the analysis we conducted for PTSD. So we saw the same positive relationship and then a buffering effect for SBW for PTSD. And so again, this was just for the physical violence victimization scale. Our next step was then to think about how this, sorry, I'm missing a couple slides. So the next step was then to look at the effect of bringing in the Marshall scale, which had these contemporary forms of violence, the help-seeking behavior subscale, and to look at the individual subscales of the SBW measure that we developed and see how it was performing in relationship to depression, anxiety, and PTSD. And during that analysis, the full model was also significantly explained about 24% of the variance in depression. So the Marcia and help-seeking behaviors were strong positive predictors of depression, which we anticipated. Those are pretty well-known findings. Among the SBW subscales, emotional concealment, self-sacrificial caretaking, and independence were significantly related to greater levels of depression. And then perseverance, interesting enough, was linked to lower levels of depression. So we don't quite know what to make of that yet. For anxiety, we ran the same model for anxiety as an outcome. Again, this full model was significant and explained about 25% of the adjusted variance in anxiety. So we similarly saw that the Marcia scale and help-seeking behaviors were strong predictors of anxiety. And among SBW subscales, we saw that emotional concealment and perseverance were the only dimensions that were significantly related to anxiety. And you'll note that, again, the perseverance subscale is operating in a negative fashion. So the higher strength of will, the less anxiety. So something to think about for us. And then finally, for post-traumatic stress, the full model again was significant and explained about 31% of the adjusted variance in post-traumatic stress symptoms. So the Marcia and help-seeking behavior subscales, again, were strong predictors of PTSD. And then among the SBW subscales, every single dimension was significantly associated with PTSD. So emotional concealment, self-sacrificial caretaking, independence, the positive relationship shielding, and strength and perseverance. So we were happy to see that the measure was performing in such an excellent way. And so we're attempting to do some more analysis to kind of unpack some of these findings. When I think about the implications for and future directions for this work, I would love to talk to you all in the room about this. But from the practice side, working with practitioners and clinicians consider the role of SBW when providing assistance and resources to Black women, we think is critically important to ensure health equity for them. So reluctance to accept help doesn't necessarily mean that they don't need it. reluctance to involve the criminal justice system doesn't mean that their partner doesn't need or deserve some kind of corrective action. And so the ways that they have been socialized to exhibit and endorse some of the behaviors and from the SBW doesn't mean that they aren't worthy and aren't worthy of or need some of the same supports and resources that other women are receiving. When considering research, we knew we were getting to this kind of complicated area that the schema is a paradox. There are ways that it has both positive and negative can result in positive and negative outcomes for Black women. And so not trying to, I think it's hard to hold both. Being both protective and having protective and risk qualities. And so challenging to the measure and to differentiate, this is something that we're working through. So the need to hold both when conducting research and during these issues, that we don't want to see SBW as only a negative or a thing for Black women. There are ways that, like you said, in some ways it's been the way, their coping mechanism to be able to survive and thrive in society. So we can't discount those positive effects, even when knowing there's some ways that it may be hampering or minimizing their ability to seek help when needed. We also were really interested in how SBW operates or doesn't when the partner is another Black woman. So in our sample, we have women who are partnered with other women. And so trying to understand what does it happen when both partners are exhibiting these different qualities, and what does that mean for their ability to care for one another. Also, we heard from women about particularly during the focus groups and cognitive interviews, that some of them were partnered with people who were partnered with men that were of a different race or ethnicity. And so sometimes they talked about the ways that they that increase their ability, they increase their capacity for vulnerability, but also may have increased their ability, increase their independence. So some of the subscales may change, their endorsement of them may change based on who the partner is. So these are all things that we need to try to unpack, and I don't know that we'll be able to do it with the data we have in front of us, but I look forward to being able to do that in the future. And then for policy, so creating policies that don't always include harsh punishment. So one of the things we heard time and time again from women is that they often don't want their partner to be jailed or in prison after experiencing abuse, that they want to get them the help that they need. And so that is why the help seeking, their help seeking rates are so low, is that they don't want the help that is being offered. It's not going to do the thing that they need them to do. And so the lawmakers need to understand that there are many ways that the laws and protection orders that they have in place are good in theory, but often just become a deterrent for them to be able to live their lives every day. So in her 2000 paper, The Icon of the Strong Black Woman, The Paradox of Strength, Regina Romero described SBW schema as a double-edged sword. She wrote that strong Black woman is a mantra for so much a part of the US culture that is seldom realized how great a toll it has taken on an emotional well-being of African-American women. As much as it may give her the illusion of control, it keeps her from identifying what she needs and reaching out for help. So over the last 25 years, intersectional feminists, psychological and public health scientists have engaged in a longstanding debate concerning the potential for positive or protective functions to manifest through the adherence to behavioral prescriptions of SBW. Research is mixed, as we talked about, regarding the buffering or the negative effects of SBW endorsement on Black women's mental and physical health. But very little of this work has focused on the impacts on their romantic relationships. And so this, as far as we know, is one of the first projects to kind of examine the influence of this endorsement on IPV, help seeking, and mental health services. And so I think there's a lot of room for work in this area, and we hope that we'll be able to continue to do it. So thank you.
And lots of time for questions, and I'll just see filled up, and feel free to grab lunch if you have it. Yeah.
Thank you.
I would like to know the
Let us say it again. The kind of design. that we use for the study. I would call it, I mean, I called it a sequential exploratory design. So exploratory sequential for those, anybody, I did a mixed methods workshop last week. So we used the qualitative to build into this quantitative measure and then examined it. So yeah, a sequential exploratory. Is that what you mean?
Yeah.
Yeah.
So I just wanted to know that quantitative is informed, right?
Yes, very much so.
And team consider intersectional analysis.
Intersectional analysis. Yeah, absolutely. So, I mean, I think that depending on how, so this was our first run of the analysis, right? Like there's a way that conducting intersectional analysis, sometimes it's about how you interpret the data, not just how you analyze it. And so we have been looking at, we will be looking at some of the other identity characteristics of the participants in the study to see how that may change or moderate the results that we're seeing. But yeah, so we're still working on some of the intersectional analysis. I will say that a lot of the quantitative analysis is being conducted by my co-PI. Like I said, I'm mostly a qualitative researcher, so I know she is very invested in the intersectional part. Yeah.
So based on the participant points, how different are your quantitative results from
How different are, say it again?
your quantitative results from data?
Oh, I don't think they're different at all. I mean, the qualitative results helped us get to the measure. Like we used the results from the focus groups to draft the items for the measure. Like we used those codes quite literally to develop those items, and then used the interviews to help refine the items to make them better. And so I think the qualitative informed very much the quantitative measure, and then we are using the quantitative measure to help understand how it is linked to other outcomes, other correlates. Yeah. Thank you.
Yeah, go ahead.
We added, and now it's you found the women. Because a number of times, in the health seeking, they will usually probably look at the sister of the intimate partner or something, the best friend of the partner. What did your data, I guess, link to what's already known out there on women's internal gatekeeping mechanisms and how that influences their behavior?
Yeah, so let's see if this will come up, was the help seeking item that we used to help to understand, to measure help seeking behavior. And so it included they could have said they got help from any of these people. So it could be their friends, their siblings, their parents, other family members. It could have been anyone, to try to incorporate, like you said, we wanted a comprehensive list. You're right. Like they could be getting help from or asking for help from anyone. And so, yeah, we tried to be inclusive as possible. Yeah.
Do you have any questions online? Just, oh, okay.
Thank you for this. This is such a really exciting presentation. Such a needed tool moving forward. I wonder if you could talk a little bit about the kinds of places like clinics or environments or community groups where you see this tool being used, and some of the supports or resources that you might reflect on needing to be in place as this tool is
Yeah.
done in the real world.
Yeah, I'm not sure. I'm not sure if the tool has a place in like clinical settings necessarily. I think, I mean, I'd be interested to see if other people felt that it did, but I don't know that it has a place in clinical settings or practitioner kind of organizations. I think the point of developing the measure was helpful for us to help call out a thing that we know is happening, but it's not being measured, right? Like, so it's not being examined in some way. And I think the idea would be to help clinicians think through, how do I talk to my clients about this? more. So making them aware that this is a factor, that this is something that they should be thinking about when they're trying to offer support or resources, as opposed to asking them to complete the measure to determine where they are in certain scales. I think that's how we've been thinking about it. So with that in mind, I think some of the, the resources or help or support that they can provide, I think has to be really tailored to them and their individual needs. I think there is, of course, no one size fits all. I am not, I'm hesitant to kind of give specific recommendations yet because I'm not a clinician, but I think that being really thoughtful to my friend's comment about the help seeking, the people and how they're seeking help. I think being really thoughtful about how they're thinking about how they might go about that differently from other clients will be important. Because I think one of the things I started off the presentation about saying is that we know that Black women seek help. They are getting help, but they may not be getting it from maybe the traditional ways or from the same sort of sources that other women are. And so being open and receptive to other sources of support, I think is something that we have to keep pushing clinicians to do and in policy to be able to accommodate for. Sometimes, we hear from from Black women in the US, and I'm sure it's the same here, is that sometimes they just need emergency funds to be able to get out, right? And so you wouldn't believe how hard it is to set policy to be able to provide money, just cash money, for them to be able to leave their partner or be able to get help that they need to evade the abuse that they're experiencing. Did I answer your question?
Yeah.
Okay.
Yeah.
I have a weird one about just what brought you and Diane together.
Yeah. So we both are members of SPR, so Society for Prevention and Research is our professional home, professional society, one of our professional society homes. And so I will say that I first learned about Dianera and I was working on my dissertation many years ago because she had conducted one of the first and only studies looking at the long-term outcomes of teen dating violence on adult women. And so I knew her name when when I met her at the conference. But that is generally how so in the same circles around teen dating violence and abuse. And so, this work is with young Black women age 18, but a lot of my work is with adolescents. And so that, mid or early and middle age adolescents. But so that's how our paths, I think, initially crossed. Yeah.
It's very sweet.
Yeah.
I also knew Katrina's work and thought she was amazing. And then SPR, which if you're a public health person is a great organization, has a really strong early career network. And so Katrina was involved as a leader of that network and I was in it. And so, yeah, we just. I have a question.
Yeah.
So the quote at the end was very powerful, but it specifically talks about the American context, which we've talked about. There are similarities, differences. So I have a two-part question. My first is, do you think this schema applies outside of the US? And then are there potential moderators? I was just thinking about colorism, where someone may be expected to adhere more or less strongly to the schema.
Yeah. Ooh, good question. So outside of the US context, I don't, that's something I'm willing to have discussions about. I imagine that it does in some ways. I think the root causes of the schema may be US centric, but I think that there is a way that the media portrayals of these kind of these stereotypes exist everywhere. Right, there's and so that I think that has to in some way affect the way that women, Black women in Canada may be experiencing or be responding to by others, right?
Because even most of the providers in the violence and women sector are white women.
Yeah,
right?
right.
Our understanding of Black women's experience.
Yeah.
From a lot of US culture.
Exactly. Yeah. So I think that it must have some role, but I'm really interested to talk to you about that. Yeah. Okay. Good. And then about moderation. So colorism. I don't know. Maybe colorism. I'm more interested. I think I'm interested in the biracial and the multiracial women and how because I think when we talk about being bi or multiracial, there a lot of times women struggle a little bit with which side of their ethnicity or identity that they feel is they're most closely tied to, and so there could be ways that they may be endorsing certain parts of SBW and not others, depending on how they've been socialized and what they feel is most central to their identity. So sexual orientation, identity for sure. Socioeconomic status. I think I don't have results from this, but one of the things we started to look at is that women who, what we're really curious about is that sometimes these, we looked at 18 to 30, right? But I am not in that age group. And many of my friends are like, oh, who are also not in that age group are like, oh, well, I don't have to do that anymore because I am now, I either have been partnered for a long time or I have healed in a way that I don't have to adhere to certain the schema anymore. So I think there are some both age and socioeconomic status kind of moderators of SBW endorsement that to be considered. Yeah.
Immigration status, like.
For sure, right? Like immigration status, for sure. Like how much you've, like whether there is some kind of, assimilation to US culture around these things. And I think that, I think SBW, is, like I said, I think it is a very US thing. I imagine that there are other schemas and other stereotypes that may exist for women who've immigrated from other places and have different cultures in there that they grew up in or were socialized to. So that's something we should think about too as well. Yeah. Very early stages.
Well, we can end now. So yeah, if you want to chat with Katrina individually, and then please take food as well. But thank you so much for making time on Thursday. Really appreciate it. Thanks, Katrina, for the great talk.